Smoking and periodontal disease. Smoking is highly prevalent and can be considered an epidemic in both developed as well as in developing nations. Globally, as many as 6.25 trillion cigarettes are smoked annually across the globe. Tobacco kills 6 million people each year. Only 50% of the people worldwide have access to smoking cessation services, and about 18% of people worldwide are protected by smoke free laws. Tobacco smoke contains thousands of noxious chemicals and it comprises of gaseous phase and solid phase. The gaseous phase contains carbon monoxide, ammonia, formaldehyde, and hydrogen cyanide, and it also contains more than 60 non-carcinogens such as benzopyrene and dimethyl nitrosamine. And the particulate phase contain nicotine, tar, benzene, and benzopyrene. This tar is inhaled with the smoke, and in its condensate form, it is a sticky brown substance that stains the fingers and teeth yellow and brown. This nicotine causes rise in BP, then rise in heart rate, increase in respiratory rate. It causes peripheral vasoconstriction and it also causes decreased skin temperature. Now let's see the effects of nicotine and smoke on periodontal tissues. Nicotine adversely affects the proliferation, attachment, and chemotaxis of periodontal ligament cells. It affects the attachment of fibroblasts. It can lead to decreased production of collagen and non-collagenous protein by fibroblasts. It induces gingival fibroblasts to produce pro-inflammatory cytokines like interleukin 6 and interleukin 8. It impairs the revascularization during soft and hard tissue wound healing. It also inhibits the expression of various growth factors. Smoking is considered as a risk factor for many diseases like lung cancer, stroke. It can cause coronary artery disease, gastric ulcer, and many cancers, and it can also lead to low birth weight babies. So, based on the CDC criteria for classifying the smokers were classified into current smoker, former smoker, and non smokers. Current smoker means they have smoked greater than or more than 100 cigarettes during their lifetime, and currently also they are smoking. Former smokers have smoked more than 100 cigarettes in their lifetime and do not currently smoke. And non-smokers have not smoked 100 cigarettes in their lifetime and do not currently smoke. And let's see what it means by pack years. Pack year means number of packs smoked per day into number of years of smoking. That means one pack year is the cumulative exposure that corresponds with the smoking of one pack of which include 20 cigarettes per day for a period of 1 year. And if a person who has smoked 20 cigarettes per day, that means one packet contains 20 cigarettes, and for a period of 15 years, then the pack year is 15 pack years of smoking. Smoking is considered as a major risk factor for periodontal disease. It affects the extent, severity, and prevalence of periodontal disease. It influences the etiology and pathogenesis of periodontal disease. It influences the response to periodontal therapy. So, the effect of smoking on the prevalence and severity of periodontal disease. Let's see what happens in case of gingivitis. Even though smokers had a significantly greater plaque index, the average number of bleeding sites in smokers was comparatively smaller when compared to non-smokers. Also, the gingival inflammatory symptoms appear to be suppressed in case of smokers. Smokers had a higher proportion of small blood vessels but a lower proportion of large blood vessels compared to non smokers. The hemorrhagic responsiveness was found to be suppressed in case of smokers, while in non smokers, an exponential hemorrhagic response to increasing plaque levels was suggested. So, based on study conducted by Palmer in the year 1987, the less gingival inflammation in smokers could be due to vasoconstriction of gingival vessels as well as heavier keratinization of gingiva in case of smokers. The next is smoking and periodontal disease, how it influences the periodontal disease. On an average, smokers were 4 times as likely to have periodontitis when compared to non smokers. And smokers had a higher mean bone loss when compared to non smokers. And smokers had more mean attachment loss, deeper periodontal pockets, and more missing teeth and fewer sites with gingival bleeding on probing, and similar dental plaque levels and gingival inflammation than those who had never smoked. So let's summarize the effects of smoking on gingivitis and periodontitis. Gingivitis, it decreases the gingival inflammation and bleeding on probing. And in case of periodontitis, it increases the prevalence and severity of periodontal disease, increase the pocket depth, attachment loss and bone loss, and it increases the rate of periodontal destruction, increase the prevalence of severe periodontitis, it increased tooth loss, and increase the prevalence with increased number of cigarettes smoked per day, and it decreases the prevalence and severity with smoking cessation. Regarding the effects of smoking on the etiology and pathogenesis of periodontal disease, when we consider the microbiological aspect, as per the study conducted by Bergstrom in the year 1989, there is no effect on the rate of plaque accumulation. And in 2001, Eggert et al. He conducted the study and concluded that smoking extends a favorable habitat for bacteria such as P. gingivalis, Pivotal intermedia, and A. comitans to shallow sites with a pocket depth which is less than 5 mm. The factor which is responsible is the effects of carbon monoxide providing growth factor for anaerobic microorganisms, and it damages the cells involved in protection of periodontium by the advanced glycation end products of smoke. So let's summarize the microbiological aspects, then immunological aspects and physiological aspects. When we consider the microbiological aspects, increased complexity of the microbiome and colonization of periodontal pockets by periodontal pathogens are seen. And when we consider the immunological aspects, altered neutrophil chemotaxis, phagocytosis, and oxidative burst can be seen, and there is increased tumor necrosis factor alpha and PGE2 in GCF, and increased neutrophil collagenase and elastase in GCF, and increased production of prostaglandin E2 by monocytes in response to lipopolysaccharides. When we consider the physiological aspects, you can see decreased gingival blood vessels with increased inflammation, and decreased GCF flow and bleeding on probing with increased inflammation, and decreased subgingival temperature, and also one more thing is there, that is increased time needed to recover from local anesthesia. So cigarette smoking can lead to decreased immunity, and it can lead to increased oxidative stress and the activation of various inflammatory cascade leading to the overproduction of interleukins like interleukin 1 beta, interleukin 6, TNF alpha, etc. All this can lead to periodontal disease. So, when we consider the effect of smoking on response to periodontal therapy, when we do the non-surgical periodontal therapy, but in case of smokers, there will be decreased clinical response to root surface debridement, decreased reduction in probing pocket depth, decreased gain in clinical attachment level, then decreased negative impact of smoking with increased level of plaque control. So, smokers will have there is no effect in relation to the increased deposits of plaque. When we consider the surgical therapy and implant therapy, there will be decreased probing pocket depth, reduction and decreased gain in clinical attachment levels after access flap surgery or flap surgical procedures, and increased deterioration of furcations after surgery, decreased gain in clinical attachment levels, decreased bone fill, and increased recession and increased membrane exposure after guided tissue regenerative procedures, and decreased root coverage after grafting procedures in case of management of localized gingival recession. When we consider the maintenance therapy, the smokers will have increased probing depth and attachment loss also when we do the maintenance therapy, and increased disease recurrence is seen in smokers, and increased need for retreatment is also associated with smokers, and increased tooth loss in smokers seen after surgical therapy. The effect of smoking cessation on periodontal treatment outcomes. Smoking cessation positively influenced the periodontal treatment outcome. Those individuals who successfully quit smoking for the entire 12 months of the study had the best response to the periodontal treatment. The benefit of smoking cessation on the periodontium is likely to be mediated through the gingival microcirculation and improvements in certain aspects of the immune inflammatory response. Smoking cessation should be considered a priority for the management of periodontitis in case of smokers. So there are brief intervention programs which include 5 A's that include ask, advise, assess, assist and arrange. That means ask the patient about his or her smoking status. Then this should include the medical history. Detailed medical history should be taken. Advise the smokers of the associations between oral disease and smoking. Then assess the patient's interest in and readiness to attempt smoking cessation, and assist the patient with his or her quit attempt, and arrange for a follow-up visit. And there include a very brief intervention program also, which includes only 3 A's that include ask, advise and act. So when we consider the pharmacotherapy, as per the FDA approved one, currently approved one include nicotine chewing gum, nicotine lozenges, nicotine patches, nicotine nasal sprays and nicotine inhalers for use in patients who are attempting smoking cessation. And one of the non-nicotine medication include sustained release bupropion. It's also approved by FDA. So to conclude, the smoke include gaseous phase as well as particulate phase, and nicotine is considered as the major constituent, and it gets quickly absorbed in the lungs and reaches the brain within 10 to 90 seconds. It causes rise in BP, increased heart rate and respiratory rate, and also causes peripheral vasoconstriction. So when we consider the smokers have reduced gingival inflammation and bleeding on probing. But smokers are highly prevalent for the progression to periodontal disease. They are 4 times as likely to have periodontitis compared to non-smokers. And former smokers were 1 to 7 times more likely to have periodontitis. And smoking reduces the positive response to both non-surgical therapy as well as surgical periodontal therapy. Tobacco smoking was positively associated with tooth loss, even when regular recall interventions or regular recall maintenance care was performed. Thank you.